Good afternoon, students. So today class is on rectum and anal canal, and there will be two classes. I am taking the first class today. We will be discussing few diseases of rectum and anal canal together, and few topics I will be dealing tomorrow. Okay. So before starting the class, I must tell you that if you are preparing for FMGE exam, then if you are preparing for 2021 exam, okay, then you can take an Unacademy subscription and you can use the code. You can use surgery 10 code, or you can use Dr Animesh 10 code and get 10% off. There will be total 19 subjects. All the 19 subjects will be covered, and these are the subjects that are going to be covered in this course. Okay, so you can attend this. Now let's start the topic. The first topic is rectal prolapse. So what is rectal prolapse? So rectal prolapse is basically of two types. Okay, first is partial. It is also known as mucosal rectal prolapse, and another type is full thickness rectal prolapse. Full thickness means all the layers of the rectum is prolapsed in full thickness. Whole wall of the rectum is included in full thickness, and partial thickness, only the mucosa is prolapsed. Usually partial rectal prolapse occurs in children and they are treated conservatively, whereas full thickness rectal prolapse are treated by surgical management, and they are mostly seen in adults. Okay, in adults the prolapse is often full thickness and is frequently associated with incontinence and are treated surgically. Okay, so any mucous membrane and submucosa of the rectum protruding outside the anus for approximately 1 to 4 centimeter is called as rectal prolapse. Sometimes it can also commences as a rectal intussusception, where one part of the intestine goes inside the other, okay, adjacent part. Now, how patient of rectal prolapse present? So in children, as I have told you, children with the rectal prolapse are mostly partial. Okay, so partial rectal prolapse are mostly mucosal. So mucosal prolapse often occurs after an attack of diarrhea or weight loss or consequent loss of fat in the ischiorectal fossa. So if there is continuous diarrhea, weight loss and loss of fat in the ischiorectal fossa, then it can lead to mucosal prolapse in children. These are actually risk factors for partial prolapse. Now mostly the children of rectal prolapse can have certain disorders like maldevelopment of pelvis or any neurological disorders or any fibrocystic disease. These problems are associated with rectal prolapse in children. And in adults, the rectal prolapse is associated with hemorrhoids. Mostly the hemorrhoids are third degree or fourth degree hemorrhoids. In female, there is a torn perineum, and in male, straining from the urethral obstruction. Urethral obstruction can be due to any cause, can lead to mucosal prolapse. And in old age, both mucosal and full thickness prolapse are associated with atony of the sphincter mechanism. So these are the causes as well as clinical features of rectal prolapse in children and adults. Now see, you have to know the difference between rectal prolapse and hemorrhoidal prolapse in adults mostly. So it is very easy to differentiate between the rectal prolapse and the hemorrhoid prolapse. See, when the mucous membrane is prolapsed, it is pink in color, whereas hemorrhoids are not pink. They are plum colored and trifoliate. Why trifoliate? Because in hemorrhoid, I will discuss about hemorrhoid today only. That hemorrhoid, the most common sites are 3 o'clock, 7 o'clock, 11 o'clock position. So mostly in these three sites, from these three sites there is prolapse. So this is known as trifoliate prolapse, or they are more pedunculated prolapse. Whereas the rectal prolapse, when the mucosa of the rectum prolapses, it occurs circumferentially. From all around the prolapse is there. Okay, but in hemorrhoid prolapse, the prolapse is only in the three position, most common position, that 3 o'clock, 7 o'clock and 11 o'clock, and they are plum colored, somewhat darkish in color, whereas rectal prolapse are bright pink in color. Now, before operative intervention, a careful history, examination and colonoscopy should be performed, and manometry should be done in case where there is incontinence. Now, there are different surgeries for rectal prolapse. There are abdominal procedures and there are perineal procedures. There are advantages and disadvantages of both. So what are the indication of abdominal procedures, what are the contraindication, what are the complications? So you should know. And what are the benefits, advantage and disadvantage? You should know about all these, because anything you may get in your exam. In exam they have asked which of the following is abdominal procedure, which of the following is a perineal procedure. They have just given the names of the procedure and they have asked which of the following is abdominal. So such questions are also expected in exams. Okay, now abdominal procedures are considered the surgical procedure of choice for young and fit individuals. What does that mean? The abdominal procedures are done in young and fit patients, and they are not suitable for old and infirm patients. Okay, because most of the time the rectal prolapse when it occur in older patient, then they are not fit for surgery. There are many other complications that can occur. If you are doing abdominal procedures, that means you are dealing with major surgery, and major surgery can have their complication in old patients. So most of the time the old patients are not fit for surgery. So these procedures are only suitable for young and fit patients. Okay. Abdominal procedures improve continence. Okay. And as it improves continence, the most common side effect of abdominal procedure is constipation. Okay. Now this is the difference between abdominal and perineal procedures. What is the difference? Abdominal procedure improve continence, whereas perineal procedure do not improve continence as much as abdominal procedure. That is why post-operative constipation is less with perineal procedure, whereas post-operative constipation is the most common side effect of abdominal procedure. Okay. Now, one more difference, abdominal procedure have least recurrence rate. Okay, means this is the difference. The perineal procedures have recurrence rate. Okay, recurrence is high in perineal and it is low in abdominal procedures. Now, what are the abdominal procedures? So, mostly the procedure for rectal prolapse is known as rectopexy. So there are different types of abdominal rectopexy. One is suture rectopexy, one is mesh rectopexy. Suture rectopexy means you are actually fixing the rectum so that it do not prolapse. Okay, so you can fix it with a suture, you can fix it with a mesh. Now mesh rectopexy can be done by posterior approach, when you place the mesh behind the rectum, between the rectum and the sacrum. When you place the mesh anterior, it is anterior mesh rectopexy. Then there is a lateral rectopexy, lateral mesh rectopexy, and ventral mesh rectopexy. Now these procedures are done by laparoscopic approach also. Okay, so abdominal rectopexy can be done by open approach, can be done by laparoscopic approach also. Now they can ask you Ripstein mesh rectopexy is anterior, posterior, lateral. So it's anterior. Wells-Evalon's rectopexy is posterior and Orlog rectopexy is lateral. Now there are other types of rectopexy. that is resection rectopexy. Okay, it is also known as Frickman-Goldberry procedure. And then there is anterior resection procedures for a rectal prolapse. Now coming on to perineal procedures. So we have already discussed the differences between abdominal and perineal procedure. Let's go through it once more. So perineal procedures are considered to be relatively minor procedure. They can be done by local or regional anesthesia like spinal or epidural anesthesia. Okay, unlike abdominal approach, they are minor procedures, so they can be done by regional. First thing that can be that can be done in old patients, elderly patients, or unfit patients. That are those who are unfit for general surgery, those who are unfit for general anesthesia. For those patients, perineal procedures are recommended mostly. Now, recurrence rate is more than abdominal, but post-operative constipation is infrequent in perineal procedures, whereas it was most common side effect of abdominal procedure. But here, these perineal procedures less likely improve the continence. Okay, so patient sometimes can come with incontinence because if you are dealing with perineal procedures, then you may damage the sphincters. So that is why mostly patient can have complication like incontinence. But constipation is infrequent. Now, what are the names of perineal procedures for rectal prolapse? Delorme, mucosectomy, Thiche encirclement, and Althemius rectosigmoidostomy. So these are three important perineal procedures for rectal prolapse, which are mostly done in old, unfit patients who do not tolerate major surgeries. Okay. Now in exam they have asked which of the following is not perineal procedure for rectal prolapse, and in options they have mentioned Delorme, Thiche, Althemius, Ripstein. So answer was Ripstein. Okay. Now next topic, student, is a pilonidal sinus. Okay, please tell me if I am audible to you. Am I audible to you, students? Give a thumbs up sign in the comment box. Am I audible? Okay, let's discuss pilonidal sinus. See, pilonidal sinus, most of the time students think that it's a congenital problem. No, it's first thing you should know that it's an acquired disease. Mostly it occurs in middle age group, 20 to 30 or 35 years of age, in males mostly, in hairy males. And students, it is also known as jeep disease because it is seen in drivers, military persons who used to sit for a long time and used to drive for a long time. Okay. Now, pilonidal sinus usually found in natal cleft overlying the coccyx. So, in between the coccyx, in the natal cleft, these sinuses are present. Now, it can be single, it can be multiple, it can be infected. But most of the time, they are non-infected pilonidal sinus. It can get infected. Most of the time, it is non-infected. When it gets infected, it can lead to foul-smelling discharge, pain, swelling. Okay, and these sinuses are more. If they are not infected, then how they are formed? So they are formed by, see, they are formed by shearing forces of the hair. Okay, these there are hairs, there are broken hairs, and the tips of broken hair cause drilling effect, and shearing forces can lead to formation of a hole in the natal cleft, and it can go deeper and can create a sinus, and the sinus is present in the midline. If you will examine the patient on inspection, you will find certain broken hairs inside the tract and nearby areas. Okay, so it consists of a non-infected midline opening communicating with a fibrous tract lined by granulation tissue, containing hair lying loosely within the lumen. Okay, mostly occurring in dark-haired individuals, mostly males, and when it gets infected, it can cause pain, swelling, and discharge. Discharge can be foul smelling also. Now, primary sinus may have one or more opening, all of which are strictly in the midline between the level of sacrococcygeal joint and tip of coccyx. Now, these sinuses, usually they are single and simple sinus direct opening. But when it gets complicated, then it can have multiple openings or it can have multiple tracts also. Okay, even the sinus has a single opening. Okay, even if the sinus has a single opening and it has got complicated for a long duration the patient is having, then it can go deep and there can be development of more than one tract. Okay, so that we should take care. We should notice on inspection, we should see whether they are a single opening or multiple opening. Now, pilonidal sinus not only occur in between the natal clefts, it can also occur in between the fingers. Usually, in the hairdressers, those who work with hair. Okay, those who deal in hairdresser or barber, they can have interdigital pilonidal sinus. Sometimes these uh, sinuses can also occur in axilla or umbilicus. Okay, now the cause or the mechanism of the formation, mechanism of development of this disease is same all over. Now, what is the treatment of pilonidal sinus? Usually, see, it is occurring due to drilling action of the hair. So when you will ask the patient to just remove the hair and regular shaving of the area, maintaining the hygiene, and if there is any hair inside the tract, then cleaning out of the tracts. So these are conservative approach for pilonidal sinus. Okay, if patient is having minor symptom, we can go for conservative approach. Just regular shaving, washing, removing all the hairs, maintaining the hygiene, cleaning with soap and water is sufficient. Now, if there is development of abscess or any pus cavity inside, then it should be thoroughly curetaged and abscess should be properly drained. Now, there are surgical approaches also for chronic pilonidal sinus. If it is not treated by conservative approach, then pilonidal sinus should be treated surgically. Now, there are different techniques to treat pilonidal sinus surgically. What are the different techniques? First, laying open all the tracts with or without marsupialization will heal the tract itself on its own. Then excision of all the tracts can be done. Excision can be done just you can excise and just leave it to heal by secondary intention, or you can do primary closure also after excision. But usually we have seen that after doing primary closure there is reoccurrence. So after excision of the tracts, after excision of the pilonidal sinus, most of the time surgeon prefer to leave it and heal by secondary intention. Okay, now after excision we can also do Limburg's flap. Limburg flap or Karyatakis procedure have a good outcome. So nowadays Limburg flap is mostly done in practice. Okay, after excision of all the tract, actually we give a diamond shape incision and remove all the sinus opening along with the tracts. Okay, after excision of all the tracts, we take a flap from the nearby skin and just it's not a free flap, it's a pedicle flap, and it's also known as rhomboid flap, okay, or Limburg flap. So this limber flap is nowadays mostly done in practice. So limber flap is used. I have explained limber flap in my classes on Unacademy. In plus classes, in special classes also I have explained about limber flap in detail. Okay, if you want to go into detail about limber flap, then you can go through those slides. Okay, and there are other procedures also, Carrier-Akes flap or Bascom procedure for pilonidal sinus. Now students, next topic is hemorrhoids. Okay, very simple topic. Let's go through it quickly. See, what is hemorrhoid? It's a cushion of submucous tissue containing venules, arterioles, smooth muscle fibers, and elastic connective tissue. Okay, these are symptomatic anal cushions. Now, these anal cushions, what it actually occurs in at three positions: left lateral, which is also known as 3 o'clock, right anterior, which is also known as 11 o'clock, and right posterior, which is also known as 7 o'clock position. So these three positions are very, very important for hemorrhoid. Actually, when we do examination by proctoscopy, we check for these three positions. Okay, mostly. Now, how they develop? What is the cause of hemorrhoid? So most commonly, when there is raised intra-abdominal pressure, that raise in intra-abdominal pressure can be due to pregnancy, constipation, obesity. When it is raised, then it can lead to development of hemorrhoids. Patient of hemorrhoid presents with bleeding, which is painless most of the time, and bright red in color. Okay, sometimes there can be mucus discharge also, sometimes there can be prolapse also. Okay, hemorrhoids cannot be palpated, best diagnosed by proctoscopy. Now there are actually two types of hemorrhoids: external hemorrhoid and internal hemorrhoids. And internal hemorrhoids have internal hemorrhoid is divided into different grades. Those grades are very, very important. Let's discuss the differences between internal and external hemorrhoid first. Then we'll move on to the grades. So internal hemorrhoid is located proximal to the dentate line, and external hemorrhoid is located distal to the dentate line. Usually external hemorrhoid gets cured on its own. Okay, first there will be pain, and within 5 days, in 5 days, that lesion will be cured itself. This is actually a feature, very important feature of external hemorrhoid. It's treated on its own in 5 days. It will be painful, and but it is self-curing lesion, and that is why it is known as 5 days painful self-curing lesion. External hemorrhoid is also known as 5 days painful self-curing lesion. Now, external hemorrhoid, if it occurs continuously again and again, then due to repeated thrombosis, there will be development of semi-ripe black currant appearance of these hemorrhoids. They are painful, and they are usually not ligated. They are mostly excised. Whereas internal hemorrhoid can be ligated, can be banded. Okay, banding is preferred for internal hemorrhoid, or you can also use sclerosing agent. We can give sclerotherapy to internal hemorrhoids. Okay, so they can be ligated, they can be banded, they can be given sclerotherapy. They are painless but can bleed, whereas external hemorrhoid do not bleed but they are painful. These are the difference. Now let's discuss the grades of internal hemorrhoid. First degree, there is painless bleeding but there is no prolapse. Second degree, there is prolapse through the anus on straining, but it can be reduced spontaneously. Third degree mein, there is prolapse and require manual reduction. And fourth degree, There is permanent prolapse and cannot be manually reduced. Now, coming on to the treatment of hemorrhoid. Treatment is indicated only in symptomatic patients. For asymptomatic patients, only conservative management is followed. Okay. Now, first of all, for symptomatic patient, or whether the patient is asymptomatic also, if there is no bleeding, we can give conservative management. Now, what is the medical therapy that we give to a patient of hemorrhoid? We give dietary fibers. We ask the patient to take salads and stool softeners like syrup grimafin, then isabgol, or we can also give these salads, okay, more and more salads in diet, high fiber diet. So this is dietary modification that is advised. Now, if patient is having first, second degree hemorrhoid and few third degree hemorrhoids can be treated by rubber band ligation. There are small rubbers and they are known as, it is also known as Baron band. Okay, they are small rubber bands, Baron bands that can be used for the treatment of hemorrhoid. They can be used in first degree, second degree, and some third degree. Now, we can also use infrared coagulation therapy for first degree and second degree hemorrhoid, but they are not usually practiced. And sclerotherapy, sclerosing agent, mostly 5% phenol in almond or arachis oil is used in first and second degree and some third degree. So for first degree, second degree, and some third degree patients, we use rubber band ligation or Baron banding and sclerosing agents. Okay. Now, second degree hemorrhoids that are not treated by conservative approach or by rubber band or sclerosing agent, they can be treated by surgery, operative hemorrhoidectomy. Or some third and fourth degree hemorrhoids are treated by operative hemorrhoidectomy. Mixed hemorrhoids means both internal and external hemorrhoids are treated by operative hemorrhoidectomy, and fibrous hemorrhoids are also treated by operative hemorrhoidectomy. Now, operative hemorrhoidectomy is actually of different types. Let's discuss. Yes, Nishant, very good. Longo-stapler hemorrhoidectomy is nowadays considered as a treatment of choice. Operative hemorrhoidectomy is of four types. One is open hemorrhoidectomy. It is also known as Milligan-Morgan procedure. Second is closed hemorrhoidectomy, which is also known as Ferguson procedure. Third is Whitman, and fourth is longo-stapler hemorrhoidectomy. Okay. Now, in longo-stapler hemorrhoidectomy, we use staplers. Okay. These staplers are actually, you should know how to identify these staplers. Have you seen staplers for hemorrhoidectomy? Anyone? So this is the stapler. Okay. See, in instrument class we have discussed about all these staplers: linear staplers, linear cutting staplers, linear non-cutting staplers, then circular staplers, and hemorrhoid staplers, and skin staplers, and other type of staplers also we have discussed. This stapler, hemorrhoid staplers, actually it is only one time use. Okay, and these are other things that you will get in this stapler, and this stapler is very much similar to circular stapler that we use in GI surgeries. Okay, but one important difference is, not only, but one important difference is it is not curved. It's actually a straight stapler, but circular staplers are mostly curved. Okay, and these are the parts that are shown here. This is direct question you may get, students. This is stapler for Longo's procedure or hemorrhoidectomy. Okay. Now, see, anal canal and rectum and anal canal, these are the diseases that are associated with rectum and anal canal. Okay, there are other diseases like rectal abscess and fistula in anal fissure. Okay, let's discuss these topics. So, rectal abscess or anorectal abscess is actually acute sepsis in the anus, most commonly seen in men, and they can occur at different sites. They can occur most commonly at the perianal region. Second most common site is ischiorectal, and then it can also occur in the submucous or pelvirectal space. Okay, there there are certain conditions that are associated with this rectal abscess. Most commonly fistula in ano. So patient of fistula in ano can have rectal abscess because this is the most common associated condition. Then patient of Crohn's disease, diabetes, immunosuppression can also have rectal abscess. Okay. So how these rectal abscesses are formed? So there is a theory known as cryptoglandular theory of intersphincteric anal gland infection. So upon infection of gland, pus which travels along the path of least resistance may spread caudally to present as a perineal abscess or ischiorectal abscess. So that is why these are the most common site for development of rectal abscess. Now how patient of rectal abscess presents? And usually abscess anywhere in the body is very painful. So it produces a lot of pain. There will be a throbbing sensation, throbbing swelling in the anal region with swinging pyrexia. Patient with infection in the larger fatty filled ischiorectal space, in which tissue tension is much lower, usually present later with less well localized symptom but more constitutional symptoms like fever. So patient can have fever, patient can have pain, patient can have swelling, and pain, swelling, fever are too much pronounced. Okay. Increased incidence of infection in ischiorectal fossa is due to poor blood supply. Now, what is the treatment? Obviously, pus anywhere in the body has to be drained. So, drainage of pus plus antibiotic is given. Antibiotic based on culture is given. Okay. Always look for potential underlying problem because there are certain conditions that are associated with rectal prolapse. So, you should look for that. For perianal and ischiorectal sepsis or abscess, drainage is through the perianal skin, usually through a cruciate incision over the most fluctuant point with excision of skin edges to de-roof the abscess. Okay. Our next topic is fistula in ano. Fistula in ano is a chronic abnormal communication runs outwards from the anorectal lumen to an external opening on the skin of the perineum or buttock. It results from anorectal abscess or cryptoglandular abscess that we have discussed. So there are other diseases that are associated with fistula in ano. See, if you are seeing a patient of fistula in ano, you must suspect these diseases: TB, Crohn's disease, lymphogranuloma venerum, actinomycosis, rectal duplication, foreign body, or malignancy. If you are dealing with a patient of fistula in ano, you should think of these diseases. Most of the time, patient can have these problems along with fistula in ano. Fistula in ano can be just an associated condition of these diseases. Okay. Now, this fistula in ano can be of different types. From high to low, it is divided into 4 types mostly, and this is actually a classification known as Parkes classification. Most common type is intersphincteric fistula. It runs in the intersphincteric space. Okay. Then there is transsphincteric fistula. It extends through both internal and external sphincters. Then there is suprasphincteric fistula, which originates in the intersphincteric plane and tracks up and around the entire external sphincter, and extrasphincteric fistula originates in the rectal wall. and it tracks lateral to both sphincters. Now you can see intersphincteric, okay, it is 1, then 2, it is starting in the lumen, okay, in the anal canal. Just see the numbers. Are you able to see the numbers? 1, 2, 3, the lumen in the anal canal. 1, 2, 3, it is starting. 4 is starting high in the rectum. Okay, fourth type, that is extra sphincteric fistula, it is arising from the rectum, whereas 1, 2, 3 are arising in the anal canal, and then 2 is going through the sphincters and opening into the skin. 1 is just intersphincteric, it is opening in between these sphincters, the outer opening, and 3 and 4. 3 is inner opening is inside the anal canal, but outer opening you can see it is going up and then around the external sphincter, and it is coming and opening in the skin. And 4th is in the rectum, and it is opening above the both these sphincters. Okay, so this is Park's classification for intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. Okay, now how patient presents with fistula in ano? Most commonly 3rd and 5th decade of life may present, and there will be intermittent purulent discharge and pain. Okay, temporary relief upon pus discharge. There is previous episode of acute anorectal sepsis that subsided spontaneously or with antibiotic or was surgically drained. Passage of flatus or feces through the external opening is suggestive of rectal rather than an anal internal opening. Complete medical history and proctosigmoidoscopy for sphincter strength and to exclude associated condition. The key point to determine the fistula in ano is site of internal opening. The points that we should take care in fistula in ano is site of internal opening, then site of external opening where the opening is external opening. We can do per rectal examination also to identify the site of internal opening. Then course of primary tract, presence of secondary extensions, and presence of other condition complicating the fistula. So these are important points that you should take care when you are assessing a patient of fistula in ano. Full examination under anesthesia must be repeated before surgery. Dilute hydrogen peroxide, or we can also use methylene blue to detect the openings. Okay, the investigation of choice is MRI, MR fistulogram, that is the gold standard, and if there is any extension, that can also be detected in MRI. Okay, the tract is not, sometimes it is simple tract, just there is internal opening and external opening, but sometimes when the disease gets complicated, there can be certain extensions also. Okay, fistulography and CT is also useful if extrasphincteric fistula is suspected. Now, what is the treatment of fistula in ano? Fistulotomy. What is fistulotomy? See, the internal and opening and external opening is identified. We put a probe. First of all, we put a dye in methylene blue dye from the external opening, and internal opening is identified. Through that external opening, a probe is inserted and it is taken out from the internal opening, and the fistulous tract is identified. Okay, now when the fistulous tract is identified, just we cut the fistula over it. Okay, fistula is cut over it longitudinally. So that is fistulotomy, and we'll leave it. That is known as fistulotomy. Fistulectomy, the procedure is almost the same up to certain step. We do methylene blue dye, we give methylene blue from the external opening, then we put a probe inside it, and then we take out the probe from the internal opening, and then fistula is identified. Then whole fistula tract is excised. That is fistulectomy. In fistulotomy, we are just cutting the fistula longitudinally, whereas in fistulectomy, we are excising whole fistula. Okay. And after excision, the wound that is created is left to heal by secondary intention. Then third technique is Saturn's wiring. Saturn's wiring, advanced flap and glues, WAFT. It is actually video assisted procedure for treatment of fistula tract. That is also used nowadays. Okay. See, whenever you are doing any procedure for fistula in NO, just take care that you should not close it, because if you are closing after excision or after any procedure, if you are closing the fistula, if you are closing the wound, then there is chance of development, then there is chance of formation, then there is chance of reoccurrence of fistula. So laying open is the best, surest method of eradication. But if you are laying it open, then you should take care that you should not damage the sphincters, otherwise patient can come with incontinence. So treatment of fistula should be done, the surgery should be done very precisely, so that problems like recurrence and incontinence are avoided. Okay. Now fistula in Animeh, there is a Gutzal rule and there is a modified Gutzal rule also. I think you must be aware of it, about it. Okay. So if the fistula is anterior, it has a straight opening. If the fistula is more than 3.5 centimeter, then it has a curved opening, and the opening is in the posterior 6 o'clock position. Okay. There is also exception for Gutzal rule, that is actually modified Gutzal rule. Now students, there is a topic anorectal malformation that is, I think, very important for you all, and you should read about it. Okay. Anorectal malformation. It's actually a complex group of congenital anomalies involving the anus and rectum as well as urinary genital tracts. So most of the time students think that anorectal malformation usually it's a problem of anus and rectum, but the urinary tract as well as genital tracts are also involved. Okay. And abnormal development of urorectal septum in early fetal life is known as anorectal malformation. There is a classification known as Ladd-Gross classification, which has divided anorectal malformation into 4 types. For one type is anal and anorectal stenosis. Type 2 is imperforate anus. Type 3 is imperforate anus with blind ending pouch with fistula, and type 4 is rectal atresia. Okay. Now there are actually 2 types of anorectal malformation. One is high lesion, also known as supralevator lesions, and one is low lesion. So actually anorectal malformation mein there are many types of abnormality. Whether it is male or whether it is female, there are many types of abnormality. Okay. Now high lesions. What are high lesions in male? What are high lesions in female? And what are low lesions in male? What are low lesions in female? This is also very important. Direct MCQ you may get in your exam. Like rectovesical fistula or anorectal agenesis or rectal atresia is high lesion or a low lesion. Okay, and also in clinical examination also, when we examine a patient of anorectal malformation, you should, by examining the patient also, you should know whether it is a high lesion or it is a low lesion. So can anyone tell me what are the signs? What are the signs where we can, just by seeing those signs, we can see that this is a high lesion? Anyone? In clinical examination, I think you are able to understand the question first. On clinical examination, what are the signs for high lesion? No, it is not UTI. Anyone else? You can also tell me about low lesions. Signs of high lesion. See, males may when it is known as high lesion or supralevator, when rectum ends above the level of levator and eye complex, it is high lesion. And low lesion में rectum ends below the level of levator and eye. Now high lesions में male में there is anorectal agenesis, rectovesical fistula, rectourethral fistula and rectal atresia. These 4 lesions are high lesions in males. Females में anorectal agenesis, rectovesical fistula, rectocloacal fistula, rectovaginal fistula and rectal atresia are high lesions in females. High lesions constipated? No. I am asking about the signs of high lesions. Or you can also tell me signs of low lesions. Just by seeing the on examination, on inspection, you can be able to tell this is high lesion. Now low lesions are known as translevator lesions. Here rectum ends below the level of levator and eye complex. What are these lesions? Males में some are complete covered anus, some are incomplete covered anus. These incomplete covered anus are also known as anocutaneous fistulas. And then there are anal stenosis, anterior perineal anus. These are low lesions in males. Females में same, complete covered anus, incomplete covered anus or anocutaneous fistulas, anal stenosis, anterior perineal anus, vulvar anus, anovulvar fistula, anovestibular fistula. These are low lesions in females. Now students, you can see that high lesions are totally different and low lesions are totally different. Okay, although the lesions are similar in males and females, but high lesions are different. In exam you may get which of the following is high lesion, which of the following is not high lesion, which of the following is not low lesion, which of the following is low lesion. Such questions you may get. Now apart from these lesions that I have mentioned, there are intermediate lesions also. Okay, I don't think they'll ask about intermediate lesions, but let me tell you, there are intermediate or known as miscellaneous lesions. In males, it is imperforate anal membrane stenosis. Females में imperforate anal membrane stenosis, perineal groove and perineal canal. Okay, so these are intermediate or miscellaneous lesions. Okay, so we have actually this topic is a big topic. I will cover this topic in tomorrow's class, same time 3 o'clock. If you have any doubt related to today's topic, the topics were very simple: fistula in ano and anorectal malformation, rectal prolapse and pilonidal sinus and hemorrhoids. 4-5 topics we have discussed today. If you have any problem, any doubt related to these topics, you can ask me. or if you have any MCQs to discuss, you can share it with me. I will discuss about these low lesions and high lesions in detail tomorrow in tomorrow's class. Okay, I will tell you how to identify uh, low lesion, how to identify high lesion just on inspection. Okay, difference between hemorrhoid and fissure. It's a very simple question. Are the anal cushions that can occur at 3 o'clock, 7 o'clock, 11 o'clock position, whereas anal fissure can be acute and chronic. Okay, acute anal fissures are, the treatment is different. The anal fissures are mostly, they are cut on the anocutaneous junction. Okay, yes, invertogram is the investigation of choice for anorectal malformation. I will discuss about invertogram. I'll discuss. Yes, on invertogram also you'll be able to detect, or you will be able to tell, yes, this is high lesion, this is low lesion. Invertogram is investigation of choice for anorectal malformation. Now, cut on the anal anocutaneous junction is anal fissure. Okay, and it can be acute, it can be chronic, and most of the time the position of anal fissure is 6 o'clock posterior. Most commonly it is 6 o'clock position posterior. But when patient is in labor, when the female is in labor, and due to labor there is cut in the anocutaneous junction due to labor, then most common site for anal fissure is 12 o'clock, that is anterior. This is again another question that can be asked in your exam. The most common site of anal fissure is 6 o'clock posterior. Direct MCQ. This has been asked multiple times before. But the most common site of anal fissure in a patient who has just delivered a baby. In that patient, the most common site of anal fissure is 12 o'clock or anterior. Okay. So treatment is also different. Okay. For hemorrhoid, obviously we have discussed so much treatment we have already discussed for hemorrhoid. For fissure, most of the time acute anal fissure are treated by conservative approach. No need to do any surgery for anal fissure. Only conservative management is sufficient. Or sometimes we can give injections also, and lotions also, creams. Whereas chronic anal fissures are treated by surgery. Okay. There is lateral sphincterotomy. First of all, earlier Lord's dilatation was used to do. Four-finger dilatation, two-finger dilatation, Lord's dilatation. But nowadays we are doing lateral sphincterotomy. That is the treatment of choice for anal fissure. Lateral sphincterotomy, where we just remove a part of sphincters. Okay, and these sphincters are relaxed so that the development of these fissures are reduced. Okay, so students, tomorrow at same time 3 o'clock I will be there and will be discussing anorectal malformation, anal carcinoma, few other diseases related to anal canal. Okay, so take care. And also in the month of January, I will be taking classes on urology, so you can attend these classes. I will be discussing urology in detail. So, see you tomorrow at 3 o'clock. Take care. Bye bye.